Trabecular meshwork minimally invasive glaucoma surgery, or TM MIGS, has been the latest buzzword in glaucoma surgery. These innovative procedures have revolutionized the management of glaucoma, offering patients safer and less invasive options compared to traditional surgeries. However, as with any medical advancement, MIGS is not without its challenges. In this presentation, we will explore the potential complications associated with MIGS, providing a comprehensive overview to better understand the risks and how they can be managed. Here are my financial disclosures. TM MIGS share many similarities and are often more effective when combined with phacoemulsification. These devices are commonly marketed to both cataract and glaucoma surgeons. While a primary challenge is that scarring and failure in the trabecular meshwork cannot be modified, there are notable advantages. TM MIGS do not cause hypotony as they are limited by episcleral venous pressure. They also do not compromise the success of future trabeculectomy and boast a significantly better safety profile compared to any open surgery or MIGS that drain into other areas. The complication rates for these devices are generally low, especially with the eye stent and hydrus. However, complications can still occur. I will provide a brief overview of some of the more significant complications I've encountered, along with strategies for managing and preventing these in the future. Here we have a Descemet's membrane detachment caused during a hydrus implant insertion. It is a rare complication in MIGS. Of 25 eyes analyzed by Kazarunian et al., there was only one case of peripheral Descemet's membrane detachment. Similarly, Gilman et al. Reported 2 cases out of 54 eyes studied. A strategic approach to managing Descemet's detachment is to introduce an air bubble into the anterior chamber. This technique utilizes surface tension to gently maneuver the membrane back into place. Care must be taken to ensure the air bubble is approximately half its final size to minimize the risk of IOP spikes while monitoring for potential blood accumulation. Peripheral anterior synechiae formation is a recognized complication following TM MIGS. Its occurrence at the inlet rather than the 3 windows indicates a more pronounced role of the inlet in drainage. PAS is notably more prevalent in angle closure amongst TM MIGS procedures. Rao et al. Studied the PAS and TM scarring after microincision trabeculectomy and GAT using ASOCT. They reported that severe scarring was seen in more than 65% of GAT eyes compared to only 31% of MIT eyes, and that the trench pattern of scarring seemed to predict the need for medications for IOP control. Moreover, post-operative PAS in 1 to 2 quadrants in the nasal incised region was seen in 12 MIT eyes and 16 eyes with GAT, while PAS in more than 2 quadrants was seen only in 6 eyes after GAT. PAS formation, of course, can also reduce efficacy, particularly following GAT. Endothelial cell loss is another complication in MIGS. Following the landmark COMPASS XD study, the CyPass microstent was withdrawn from the market due to significant ECL, endothelial cell loss, compared to the cataract surgery group. Conversely, there was no significant differences in ECL between the phaco-eye stent and phaco-hydrus implants and their cataract surgery-only control groups. According to Ahmed et al., mean percentage decrease in ECL at 60 months was 14.3%, plus minus 13.4% in the eye stent inject group, and 14.8% plus minus 10.3% in the cataract surgery alone group. Similarly, according to Fia et al., hydrus implantation showed changes in endothelial parameters comparable to those seen with cataract surgery alone. The higher ECL absorbed with CyPass microstent compared to eye stent and hydrus implants can be attributed to their anatomical positioning within the eye's angle. The CyPass microstent, located in the supraciliary space, follows the curvature of the inner sclera, placing it closer to the peripheral cornea. This vertical orientation increases the risk of contact with the corneal endothelium, potentially causing mechanical trauma and therefore higher ECL. In contrast, iStent and hydrous implants are inserted within the Schlemm's canal, with the iStent's short nozzle protruding further from the endothelium, and the hydrous microstent lies parallel to the iris, continuing into the canal. These positions keep them further from the cornea, reducing the risk of endothelial damage and contributing to lower ECL compared to the CyPass microstent. Another potential complication in MIGS is implant dislodgement. For instance, in a video, a hydrous implant is seen diving down, a situation commonly encountered by surgeons. If the implant fails to stay in its intended position, it can cause discomfort and functional issues such as eye overpressurization or canal compression. Repositioning or removal may be necessary to prevent further complications from the dislodgement. Repositioning involves carefully grasping and reinserting the hydrous to ensure it functions properly and remains correctly positioned within the canal. Iridodialysis is a rare but significant complication that can occur during MIGS procedures. It involves the detachment of the iris from its root at the ciliary body, resulting in abnormal iris positioning, irregular pupil shape, changes in iris dynamics, and potential visual disturbances. In the Horizon study, which compared cataract surgery with the implantation of a Schlemm canal microstent versus cataract surgery alone, one case of iridodialysis was reported among 369 eyes after hydrous implantation. This complication can be challenging to manage, as demonstrated in this video, where iridodialysis occurred during the placement of a hydrous implant following a particularly difficult phacoemulsification. The patient's significant movement during surgery contributed to approximately 40% iris detachment, albeit with minimal bleeding. To address this complication, 2 Hoffman pockets were created and 10 zero-proline sutures were carefully used to reattach the iris. Postoperatively, the iris achieved a near-normal appearance, highlighting the successful management of this challenging scenario. Transitioning to complications associated with eye stents, achieving precise placement of eye stents is crucial for efficacy. Initial insertions may induce apprehension, but proper technique ensures accurate placement and function. During training, assisting with gonio lens placement can enhance confidence. Care must be taken during subsequent insertions to prevent corneal striae and injector tilt, which can hinder correct delivery. Instances of overinsertion or bias can compromise device performance, requiring careful adjustment for optimal positioning within the trabecular meshwork to ensure effective drainage. Improper placement may lead to dislodgement, necessitating repositioning using a blade or the injector, with options for intraocular or extracorporeal reloading. In this context, intraocular reloading was employed. Caution is advised with eye stent inject due to the limited 4-shot capacity per procedure, emphasizing the need for judicious use. The GTW model's larger flange helps mitigate risks of overinsertion, while the iStent Infinite allows unlimited reloading attempts, facilitating optimal repositioning without shot limits. A phenomenon known as pinball visit occurs when an improperly inserted iStent detaches and moves within the eye. This requires precise retrieval under gonioscopic guidance using Kawai forceps, followed by rethreading and reinsertion to restore proper function. In another case, an eye stent became lodged behind the IOL. It was carefully rethreaded and reinserted into the correct position. When dealing with superficial insertions, a trocar can be utilized to stabilize the stent into a more secure position. Care should be taken to avoid placing irrigation aspiration tools too close to the eye stents to prevent displacement or disruption. Hyphema is a common occurrence in TM MIGS procedures, with wide variability in its incidence across studies. For example, Seek et al. Found that 17% of the eyes experienced transient hyphema in their study, comparing standalone KDB and combined KDB with cataract surgery. In another study by Fellini et al., hyphema was identified as the most common complication, with incidences of 3% in the KDB group and 14% in the trabectome group. Fortunately, hyphema is typically self-limiting without significant clinical implications. However, larger hyphemas may require evacuation, especially if there is an associated risk of elevated IOP or corneal staining. Trabectome procedures may lead to more frequent hemorrhage and long-term intermittent hyphema due to their larger drainage area. The iridodialysis observed here was caused by the KDB procedure, emphasizing the necessity of maintaining a clear surgical field. This condition can result from applying excessive downward force during the procedure, while excessive upward force may lead to Descemet membrane detachment. However, such complications typically do not require repair unless they are severe. In conclusion, although complications are a natural part of learning TM MIGS, proficient management skills are essential for handling various devices. Ensuring thorough patient education and adhering to best practices without taking shortcuts are key to achieving optimal outcomes. Setting realistic expectations and striving to exceed them is crucial to patient satisfaction.